Good morning, everyone. Welcome to VesCell Healthtalks number 14, The Unseen Signal, Understanding Ischemic Disease, Pain, and the Future of Care. We will begin momentarily. We're going live across Facebook, LinkedIn, YouTube, and X. Please stand by for just a few seconds. Okay. Here we go, friends. Let's dig in. VesCell Healthtalks number 14. Good morning. My name is Karoom Lawrence, Chief Commercial Officer and Head of Patient Care for Hemostemics, a unique stem cell platform focused on ischemia, which is the restriction of blood flow that manifests in different diseases in the heart, limbs, skin, and brain. We're going to talk about an autologous stem cell therapy today focused on pain. Millions of people suffer from chronic pain, and there are lots of reasons behind that. But we believe millions suffer needlessly. If you get to the root cause of disease, there's a better chance of addressing pain, getting out in front of it, and moving past it, versus just treating pain symptomatically. Our particular kind of pain that we think about and work on is pain due to ischemia. So think angina, pain in the heart caused by heart disease, atherosclerosis, restrictions of blood moving through limbs that can result in lower extremity pain, often referred to under the disease heading of peripheral arterial disease. Obviously, open wounds are painful. Strokes and heart attacks are painful. We're trying to work from a sense of no option, where people feel like they've run out of options to treat their pain or their cardiovascular disease, to a new option, which are your own stem cells. We're going to talk about the pathways to accessing care through clinical trial settings or commercial settings, and then really focus on our mission, which is extending life so you're living better longer, but not living longer with disease or living longer with pain, which is misery. So our mission is transforming ischemic disease by restoring blood flow and extending WellSpan. On all of our VesCell Health Talks, we invite our professional audiences, we invite our patient communities and their families who are searching for hope beyond conventional treatment. We focus on our business purpose. We invite all of our investors to come to learn about the revolution in regenerative medicine. And then we invite our payers and anyone in Medicare, Medicaid, and government focused on how can we create highly cost-effective solutions to reduce the cost of care, because we know that cardiovascular disease results in billions of dollars. Our product, ACP01, angiogenic cell precursors, are a type of stem cell that are drawn from your own blood. They're called autologous stem cells. It's a simple blood draw. We take cells out, your stem cells out, reculture them to have a purpose. That is to regrow blood vessels. And that is our patent-protected solution that we've had about 20 years of clinical development. So our mechanism of action of the cells is to migrate to sites of ischemia, to where there's injury in the body, to promote new blood vessel growth, to reduce inflammation, and enhance tissue repair. We have numerous clinical studies that we've been working on. Then you can look at our body of knowledge of 7 published studies and 12 peer-reviewed and published articles focused on chronic limb-threatening ischemia, which is where someone's at risk of an amputation, potentially foot and leg, due to peripheral arterial disease. Angina, pain in the heart caused by heart failure. Ischemic dilated cardiomyopathy, which is related to left ventricular dysfunction, which is the ability for the heart to pump blood. Congestive heart failure, pain, and then emerging applications in vascular dementia. So we've talked about that in the past. When you have a stroke, there is restriction of blood flow to the brain that causes cognitive impairment. And so that is something else that we are investigating. And then finally, we published a really great article in Cells magazine around brain-computer interfaces, where Elon's company Neuralink and many others are implanting computers in your brain so that you can control a cursor or play video games, or you can take action. And there's an incredible body of knowledge coming where your thoughts can now control computers and devices. And those interfaces cause scarring in the brain. So ACP01, by regrowing blood vessels, can help improve the fidelity of those interfaces. So we're very excited about that. We've had 498 patients treated across 7 trials, 318 subjects in those trials, and we've got a series of phase 1, 2, and 3 studies coming, which we're excited about. Hemostemics is an autologous stem cell therapy platform company founded in 2003, winner of the World Economic Health Forum Technology Pioneer Award, developed and patented our autologous, patient's own, blood-based stem cell therapy, VesCell, ACP01. As mentioned, we've completed 7 clinical studies of 318 subjects. We've published in 12 now peer-reviewed publications. It's an investigational study, and it has ongoing safety and efficacy studies coming. So, there's a lot happening at the company. In the news, we've just filed for IRB approval for vascular dementia, which we're excited about because we think that is a huge breakthrough and an enormous amount of pain in families where one of our mothers or fathers or parents or aunts or uncles is losing cognitive ability due to a stroke or due to a microvascular disease that occurs over time. So we'll keep you posted on all that. There are a number of resources that we're bringing forward to help our patients and our physicians on board to care with hemostemics, including the opportunity to upload medical history documents into a secure HIPAA environment, to look at all of our certifications and licenses as a global biotechnology company, to look at our scientific studies and areas of expertise, and check out our socials. So we're live and active on YouTube, Facebook, Instagram, LinkedIn, and X, and many others. And there are lots of resources that we have available for physicians and patients and clinics around the world that are interested in this unique type of care. It's important to offer these disclosures that ACP01 is investigational and not FDA approved for commercial use. However, it is available in Florida and other states where pain and wound care and orthopedic care has been flagged under state regulations to provide a legal pathway for physicians and patients to agree that stem cell therapy, as long as you stay in your swim lane, clinically can be offered for patients that need it. Patients have to require to provide their informed consent to be made aware that these are not FDA-approved treatments, that treatments are currently out of pocket. We're doing everything we can to lower the cost of care to provide access for everyone, and that this presentation provides educational information and is not medical advice. I'm not a doctor. I've been on the commercial side of biotechnology for the past 25 years, and I'm excited to share this content with you. Please always consult your healthcare provider before making treatment decisions. These are our references for this presentation relative to general pain, treatment guidelines and clinical information, economics and cost of care data, Florida-specific information, patient testimonials, and then these are our published and peer-reviewed papers, of which we now have 12, focused on the role and value of autologous stem cell therapy. So let's dig into ischemic pain, what I was thinking about as the body's complex alarm system. The body sends out signals, and it breaks down into the hardware, which is neural detection. Specialized nerve endings called nociceptors detect harmful stimuli like wounds, heat, pressure, chemical imbalances all through the body. These signals travel through the spinal cord directly to the brain's processing centers. And then the software, the more psychological side, the emotional side, where the brain can interpret pain through an intricate lens of emotion, memory, and psychology. Fear and anxiety can amplify signals dramatically, while hope and distraction can dampen them. And so we will talk a lot about both the physical side of pain, the emotional side of pain. Pain is deeply personal and subjective. Many people have very high pain thresholds. It is often discussed that women can take on more pain than men, which I think is probably true, right? And well documented. So pain is not just about physical pain, but there's emotional pain, and there's lots of complexity around that. Most people, if you've been in pain, have had a chance to look at a classic pain scale from 0 to 1, no to minimal pain, through 2 to 3, 4 to 5, 6 to 7, strong pain to very strong pain, to the worst possible pain that is unbearable and the maximum pain imaginable. Your clinician will ask you, what kind of pain are you in? And this is a way to indicate whether it is acute or whether it is chronic, but it gives your doctor a sense to understand how you feel about your pain in a very rudimentary way. As pain worsens over time, there is a significant psychological and physical burden that patients bear. First, many people are shocked and they try to resist the pain. They try to be long-suffering, to tough it out. Where a patient is persisting to struggle with their pain, they might feel diminishing hope. They're very reliant on their physician. Their doctor is their key partner. They're balancing a sense of hope and resignation, eager for anything to mitigate pain. Often at end stage pain, there's a sense of being overwhelmed, of dropping out, a significant loss of hope, accompanied by things like anger and increased isolation, where pain feels uncontrolled, unmanageable, out of options. And it is a cycle of deconditioning that is extremely difficult. Our role in that is to understand ischemia, where there's restricted blood flow in the body, the slow suffocation of tissue. So there's normal aerobic metabolism where cells are using oxygen as clean, efficient fuel. Oxygen is one of the body's main power sources to produce health and energy with minimal waste. Ischemia is also an anaerobic crisis. So without oxygen, cells switch to an emergency mode. This inefficient process produces minimal energy and floods tissue with toxic lactic acid, right? So there are different effects of ischemia, restricted blood flow, on the body. Atherosclerosis creates dangerous arterial bottlenecks, resulting in chemical buildups that feels like burning activated nerve endings and sending continuous pain signals to the brain, an alarm that tissue is dying. And that's actually what's happening. So you could even think about angina as an early warning system. We've talked about pain in the heart. Sometimes I'll have discomfort in my chest if it's an extremely stressful week. I'm 54, and if I'm feeling discomfort in my heart, I get very worried, right? You hear all the time of people my age who have a heart attack for different reasons, whether it is a genetic reason or a stress reason or just not taking care of yourself, or from ischemia, right? You might feel chest pressure, squeezing, pain radiating outwards, shortness of breath, dizziness or fainting, nausea, extreme fatigue. But these are signals that something is wrong, and you're feeling that in your chest. And we're going to talk a lot about angina as a form of pain, but as an early warning system. If you have discomfort in your chest for whatever reason, you really need to consult your physician. And we're going to talk a little about some of the diagnostics that you'll probably use, including stress tests, walking tests, EKGs, things of that nature, electrocardiogram, to measure what's happening in the heart. The scale of the problem in America is huge, right? We all know about the Western diet, and we don't have to go too far into that because everyone is thinking about that all the time. But there's 60 million people living with chronic pain, and there are 21 million or so with high impact or very severe pain where they're really limited in what they can do, work, socially, etc. And then cardiovascular disease driving a very large portion of the pain burden. And also cardiovascular disease leads to worsening conditions like heart attack, stroke, and death. So pain is a signal that you need to take action. Okay? At this point, I wanted to flag Florida's legislative leadership in acknowledging pain and also wound care. Those are two things that Florida has flagged in Senate Bill 1768, activated and live as of July the 1st, 2025, which is a legal pathway forward. It's landmark legislation where Florida says stem cells and regenerative medicine is so important. We're going to provide a pathway for physicians and patients to learn about using stem cells to mitigate pain, to get the underlying cause of pain, and authorizing, in our case, autologous cells, using your own stem cells to be recultured, put back into you at the site of ischemia, in a safe and effective manner to try to mitigate that pain. We think that's a great initiative, and we applaud Florida. And there are many states right behind Florida: Texas, Arizona, Utah, Oklahoma, Missouri, Georgia. These states also recognize the value of mitigating pain and many other conditions using stem cells, and so that's an exciting opportunity. Let's talk about the clinical data in the world of regenerative cardiology that Hemostemics has published. So we've talked about a little bit of the role of the mechanism of action in precision, regeneration, and cardiovascular disease. There are two key words. One is angiogenic, which is talking about restoring blood flow. Angiogenesis, restoring blood flow. Autologous means they're your own cells. Because they're your own cells, there's a particular level of safety. There is your body is not going to reject your own stem cells, and these cells are ethically derived. They're not coming from umbilical cords or any other external sources. They're your own cells that are isolated through a simple blood draw. They're then cultured to activate new blood vessel formation, to reduce harmful inflammation while creating a healing environment for cardiac tissue to regrow. The targeted delivery is important. If you inject stem cells directly into your blood, many of them are consumed by the liver and the spleen. So we inject, for example, for limb care into the calf muscle, or wound care directly to the wound. In case of angina and cardiomyopathy, directly to the heart. For brain and dementia, into cerebral spinal fluid, your spinal fluid, so that the stem cells can have direct access past the blood-brain barrier and have access to the ischemia that's happening in the brain. So that matters as it relates to delivery. We're going to talk a little bit more about that. This slide talks about the cellular level of ACP that is releasing vascular endothelial growth factor, VEGF, and angiogenin that are programmed specifically to form endothelial cells that promotes the angiogenesis and improves circulation. CD34 stromal cells are essential to angiogenesis, participating in cell migration, control, and organization of the extracellular matrix scaffolding, immunomodulation, neurotransmission, control, and regulation of other cell types, and regeneration. Our ACP cells exhibit a high degree of CD34 plus expression, and so on. I hope you will consider looking at our clinical studies where we unpack the mechanism of action, or give us a call. The science is fascinating, and the more you know and appreciate and understanding what's happening at the cellular level, I think the more you can believe and trust that ACP has a safe and effective profile, right? And we're going to talk about our clinical studies that are beginning to demonstrate that. So clinical safety is number one in the clinical studies. So as you develop a biotechnology product or a stem cell product that's regulated like a biotechnology, you start with animal testing, then you have safety testing in humans. For example, you could have 10 to 20 humans in a phase 1 study. It's 100% focused on safety. Then you get to phase 2 and phase 3. Then now you're looking to show efficacy and safety and focus in on who is the appropriate patient candidate for that therapy, and then on down towards FDA approval. So I'm now going to walk you through some of our phase 1 and phase 2 data where we've been investing to show across 7 published studies. We had 298 patients. We have had one death, which is a patient that had an unrecognized silent myocardial infarction, which is a heart attack, 2 weeks before receiving treatment. So that's a function of screening that patient. But the stem cells themselves generally are safe. And I'm going to walk you through that data where we've studied angina, ischemic heart disease with continuous angina or heart failure, end-stage ischemic and dilated non-ischemic cardiomyopathy, severe cardiomyopathy, chronic limb-threatening ischemia, and wound care, and the healing of ulcers. So these are various studies, open label studies for the most part, and you're seeing 298 patients have received therapy, and they've studied at these esteemed institutions. You can see the logos below. Our ACP01 is generally regarded as safe because they are your own cells, and it's a simple blood draw, an office procedure. We're avoiding anesthesia, no complications associated with bone marrow harvest. There's a general perception of safety of autologous cells because they're your own. There's no risk of tainted blood, no risk of parasites, no viruses, no pathogens, no neoplasia from pluripotential cells, no ethical concerns as with fetal tissue, and no transmissible spongiform encephalopathy or Jacob Creutzfeldt's disease, known as mad cow's disease. So that's a general overview of our findings. As it relates to heart failure, I'd like to shift now into the importance of understanding the diagnostics behind our studies, which are really exciting. First of all, the CCS angina scale, the Canadian Cardiovascular test, focuses on angina and the evolution from 1, 2, 3, and 4 levels of pain in the chest, where 1 is very little, 4 is a lot. The 6-minute walk test, the exercise capacity through metabolic equivalence, the METs, and then perfusion defect. This to me is one of the most interesting, where we have nuclear imaging visualizing the myocardial blood flow to identify ischemia or lack of blood to the heart. So we're going to look at some data in a minute that shows where we can improve how much blood is getting to the heart, which is key to reversing heart failure and reducing angina, which is pain in the heart. ACP01, efficacy in ischemia and dilated cardiomyopathy, which is heart failure. I'm reading now from 2 of our studies, ARAM and Ring Sakrak, which is a study looking at the efficacy of intramyocardial injection of angiogenic cell precursors for ischemic cardiomyopathy. 20 patients with ischemia, 21 with dilated cardiomyopathy. We're looking at improvements in the New York functional class, improved 2.69 preoperatively, down to 1.63 for the dilated cardiomyopathy group. The 6-minute walk test showed improvement of 126 meters, and the injection fraction of both the ischemic cardiomyopathy patients and the dilated cardiomyopathy patients improved 4.8%. This study, it's a third study in the area of cardiomyopathy. The Canadian Cardiovascular score decreased from 2.63 to 1.53. That means going from feeling significant pain in your chest to feeling almost no pain, where the ability to walk has improved, so your exercise levels improved, and the left ventricular ejection fraction improved, which is the ability for your blood, your heart to pump blood, has improved from 34.4 to 39 post-treatment at 2 to 4 months. It's a pretty rapid onset of improvement of blood flow coming from the heart in that study. ACP01, efficacy in treatment of severe angina. So this is another study, DAMRAS, the intracoronary ACP01 injection, 24 subjects with intractable angina. CCS decreased from 2.1 to 1.05. So that's from feeling pain down to feeling almost no pain. The 6-minute walk test increased by almost the length of a football field at 3 months. So the ability to walk has improved. And the perfusion defect, this is one of, I think, the most interesting, going from 38% to 21%. That means that before 38% of the heart was not receiving blood, now only 21% of the heart is not receiving blood. It's improving blood flow to the heart. That lowers pain, angina, and it also decreases the risk of another heart attack and things of that nature. This is investigational, and you're looking at 24 subjects with intractable angina. So when you have a phase 1 or a phase 2 study that indicates this type of data, it suggests you need now to move forward to a phase 3 study and then on to FDA approval for use. So we were encouraged by this data. This is another study, a safety and outcomes analysis, and I'll just indicate here in this safety and outcomes analysis of transcatheter implantation of ACP01 for patients with left ventricular ejection fraction with ischemic heart failure before 29.9, after left ventricular ejection fraction to 38.2, which is a 24% increase, p-value 0.004, significant. And then for non-ischemic heart failure, we're showing a 47% increase of left ventricular ejection fraction, p-value 0.003, significant. That is quite compelling. We also in this study delivered a quality of life outcome survey where 66% of the subjects said they felt they had a higher quality of life better, 28% the same, 6% worse. I will again state that there were complications in the study. There was 1 death, a patient with an undiagnosed silent myocardial infarction 2 weeks before the transplantation procedure, and then 2 patients with tachyarrhythmias requiring cardioversion. So we'll continue to sort of live out of our clinical studies, our phase 1 and phase 2s, as we progress then to phase 3. And I hope if you have any questions, we would love to hear from you, and we'll go through the study data together. So let's talk about now treatment for critical limb ischemia. We have been covering heart failure. Now let's go to ischemia in the legs, the lower extremities. This is generally a function of peripheral arterial disease where someone is beginning to feel aching pain in their calf to a burning foot, which is impacting their ability to walk, which impacts their ability to exercise and to have a healthy system. It's a cascade, and it's horrible, right? It's an amputation cascade. So peripheral arterial disease, which is impacting people's ability to walk, to chronic limb-threatening ischemia, where you might have open wounds. You might have a podiatrist that's looking at your toe or toes that is losing sensation, that has wounds, that is potentially even has dying tissue. It might have gangrene. At that point, gangrene is extremely dangerous and can get infected. Your doctor might recommend that the amputation of the toe or amputation of the limb. And this needs to be addressed. So there's an enormous cost to the system in the billions of dollars and several $100,000 over several years. So when you look at people with chronic limb-threatening ischemia, studies show $100,000 to $400,000 cost over 5 years, driven by cost of amputation, surgeries, rehabilitation, prosthetic limbs. And so what we're saying here is that by shifting to a regenerative biological model that can heal wounds, that can restore blood flow, that can prevent the amputation, can bring healing back to the limb, we can save lives and limbs while alleviating an enormous financial burden to our patients and to care overall. The state of Florida recognizes this. The burden of ischemic pain in Florida is, as a huge hotspot for chronic limb threatening ischemia. There are 105,000 Floridians now experiencing burning pain at rest with their limbs, in their limbs, and it is a growing issue. So there are more than 1 million with coronary artery disease, more than 500,000 with angina and peripheral arterial disease, and then over 100,000 people, right now that are at risk of having an amputation. And so we would like to talk about that. So these are our 3 studies in chronic limb threatening ischemia, where your doctor is saying your wounds are untreatable, you are at risk of having an amputation. And so we're going to talk about Zabo, an open label study with 20 patients, Henderson, which is a reanalysis of 47 patients of a phase 2. And we're going to talk about Multiranga, which is a phase 1. And let's dig into that data. So for CLI patients with no revascular options, in other words, the doctor, your vascular surgeon has said, we have tried stents, we have tried vascularization procedures to improve blood flow to your limb, to your legs and your feet, and we've been either unsuccessful in doing that or you're not a candidate for doing that for various reasons. And so 12 patients at 2 treatment centers with CLI, 10 male, 2 female, average age of 76, were able to take ACP01, angiogenic cell precursors, from their own blood, their own stem cells, where 3 patients had ischemic rest pain, 8 patients had ulceration, and 1 patient had gangrene. Post-treatment, 1 patient with unremitting rest pain and toe gangrene did require a below-the-knee amputation, and 1 patient with gangrene of the first to the third toe required a 4-foot amputation. In the remainder, N of 10, sample size of 10 patients, healing of ulcers and resolution of ischemic rest pain occurred. Around 83% in our poster presented to the Society of Vascular Surgeons, an early read demonstrated healing of ulcers and resolution of the ischemic rest pain. We were able to save limbs where more than 80% were able to keep their limbs. They did not have to undergo amputation, and it was maintained for up to 4.5 years. So this is an important poster, again, presented to the Society of Vascular Surgeons, again, saying if a vascular surgeon says you're not a candidate, you're a no option candidate for an amputation, consider ACP1 was injected in this case back into the calf muscles with a result of improving ulcer and resolution of ischemic rest pain. Durability up to 4.5 years. And the study on a small sample size. This is a phase 2 study ultimately. Again, not FDA approved, an indicator in the study that we should proceed to phase 3 testing, which we are doing. Okay. I will just quick mention here the results of this multi-center phase 2 clinical trial. ACP01 healed ulcers from chronic limb ischemia using paired t-tests for initial to visit 7 in each group. Statistically significant decrease in ulcer size. The ulcer size reduced from 1.5 centimeters, about the size of a small strawberry, to 0.5 millimeters, so half a millimeter, which is about the size of a grain of sand. So the wounds healed from the size of a strawberry to the size of essentially a grain of sand by restoring blood flow. So there's a trend to fewer amputations and deaths, fewer deaths with ACP. In the test group of N of 21, we had 4.8 amputations and 4.8 deaths within 12 months, 4.8% of the test population. The placebo, N of 8, 25% had amputations, 25% death rate. And that 25% really aligns with general Medicare studies on the amputation and death rate just on average in the broad population. So we're looking at directionally improvement in reduction in amputation, reduction in mortality. And we see a very high mortality rate, not only in year 1, but in year 5. So the reason we looked at 4.5 years was to say, if you can save your limb, your life will be extended beyond what is, I believe it's a 50% mortality rate in year 5, if not worse than that. So that's how we focus on our longevity story, right? Which is what we want to do: live better, longer, not live in pain longer. So let's talk about accessing care through hemostemic. So we have a roadmap to accessing ACP01. There are several pathways that we are exploring. The most important one is our clinical trial program with phase 1, phase 2, phase 3 studies, where we have IRB submissions for FDA review, which allows us to invite patients, qualify them for our clinical studies to receive care, and then we read out that data back to the FDA to advance our clinical trial program. We also know that in the state of Florida, under Senate Bill 1768, Florida has provided a legal pathway under very specific circumstances for patients with wound care needs and pain. So our autologous stem cells are available, specifically through the legal pathway in Florida, and we're also investigating the other states that are looking at a same pathway. So we've talked about Florida, our clinical trial access, and then we have global access points. So there are stem cell clinics around the world that also will be providing ACP01, in specific circumstances for U.S. citizens or for other people around the world that seek care and seek ACP01 to regrow blood vessels and to reverse or impact ischemic disease that results in pain, angina, heart failure, left ventricular dysfunction, cognitive dementia, the areas we've been talking about specific to ischemia. Sick care is expensive, and we're focused on breaking the cost cycle by getting to the root cause of disease. So we're focusing on year 1. Our investments are coming through to get FDA approval for ACP01 and looking at break-even points to help our patients avoid costs in year 1 and year 2 and help the broad system, healthcare systems, reduce costs by reducing hospitalizations, reducing surgeries, reducing ER visits, and reducing all other interventions to generate savings and long-term sustained value for patients in the healthcare system. We have a standardized clinical care workflow where working with your physician in strong partnership where your physician and you agree that you'd like to try stem cell therapy. So your patients are referred to us through your physician, or you could access care through us directly if that's what you'd like to do. And we establish a qualification. So we ask for you to send us your last several years of diagnostics, echocardiograms, cognitive tests, x-rays, anything we need for our trained clinicians to review your diagnostics to determine your eligibility for VesCell therapy or not. And if you are not a candidate, we will tell you if you are a candidate and we believe you can take ACP01 safely and achieve a healthy outcome. We'll let you know. It's important also to mention that our clinical care workflows essentially mirror the clinical trial protocol set up through our IRB and FDA approved process. So the way we qualify you, the way we review your diagnostics, request further diagnostics to get you qualified, go through care to be screened, treated, and monitored to get real world data. The clinical pathway and the commercial pathway are essentially the same. You will then be onboarded through one of our care specialists. We'll talk about payment, financing options, how to schedule travel, coordinating the blood draw to extract your stem cells to have them re-injected into you 7 days later, and then into care monitoring and real world follow-up of that data. There are several ways to access care. As you know, because we are not FDA approved and because we do not have reimbursement. We have low monthly payments we've arranged through several healthcare specialized financing partners. We have a 501c3 foundation for patients that need care. We will often ask those patients who are affluent if they can afford treatment for themselves, but also donate a therapy to the 501c3 for someone who needs help and can't afford it for themselves. And then for our investors, we have a treatment convertible debenture. So if someone wants to invest in the company, they are able to do so. They can purchase a treatment through that investment, and then that treatment can be reserved for them for when they need it. And we can talk more about that for anybody who's interested in learning about the treatment convertible debenture offering. We tend to go to Q&A now. I know we are live streaming. I don't know that I'll be able to see your questions coming in, but I'll look at the dashboard in a moment. But I hope you'll join our community. We're focused on all the topics we covered: regenerative medicine, longevity, pain reduction, healing wounds, saving limbs. Saving a limb is saving a life. We are living and breathing out of our clinical data. That's our true north. We invite you to read those clinical studies, ask us about that, and please connect with us and our leadership. Again, my name is Karoom Lawrence, Chief Commercial Officer, Head of Patient Care. You can reach me at clawrence@hemostemics.com. You can reach our Chief Medical Officer, Dr. Fraser Henderson. You can reach our CEO, Thomas Smink. Please visit us at hemostemics.com. Visit our longevity clinic site at VesCell Health, VesCell.health. And then Hemostemics Clinical Trials is where we have a place to invite you to register for our trials as they become IRB approved, or just submit your name to get on our newsletter and to hear from us and to stay running alongside of us as we work towards bringing what I think is a breakthrough in care, for all the reasons we've discussed. Thank you so much for attending. We will close now. We have these webinars every Thursday. Sometimes they push to Friday, but I hope you'll come back and send us your questions. Let us know what you need. We would love to hear from you, and thanks for being in touch. Have a great Friday, everybody, and we appreciate your time. Take care.